folks. Let's talk about pediatric traumatic emergencies today. We're going to start off by talking about mechanism of injury and pain relief, or analgesia therapy for pediatric populations. So let's start off by talking about mechanism of injury. So as you know from EMT school, this is how the patient gets hurt. This is how the injury occurs. So mechanism of injury, that is the object or the act that led to the injury. So one thing to keep in mind is that trauma is one of the leading causes of death in the infant and child populations, with the number one culprit being blunt trauma. And that's a pretty vague subject. But I want to talk about 7 different criteria or mechanisms of injury. First off, we'll talk about falls. Then we'll talk about motor vehicle collisions, vehicle versus pedestrians, drownings, penetrating injuries, burns, and we'll end up with physical abuse. And keep in mind, we're not going to talk about specific injuries. We're just strictly talking about the mechanisms and the age groups for which they typically affect the most. So let's start off by talking about falls. All right, giggity goo. Falls are the most common cause of injury. Falls from bicycles account for a significant number of injuries. And again, I want you to think about, we just talked about how blunt trauma was the number one cause of traumatic death. So falls are the number one cause of traumatic injury. So think about helmet use, think about all the different types of things that can contribute to greater injury. Children younger than 5 years of age are at the greatest risk of incurring fall-related injuries. So again, if you think about that age group and how we've already discussed in previous lectures, how they are very adventurous, they start moving around and they have a very imaginative mind at that age, so they're going to get into a lot of stuff and fall off of a lot of stuff. More than 80% of fall-related injuries in the children younger than 4 years of age occur in the home. So that's something to think about. Whenever we think about falls, typically we're thinking about outside, like in school or playground, something like that. But typically, these injuries will occur in the home. Infants are at risk for falling from furniture or stairs. So that's kind of common sense. Think about, again, they're learning how to crawl. Some of them may be trying to pull themselves up onto coffee tables and things of that nature to help stand up. So think about things like that whenever we talk about these little folks. Toddlers are at risk for falling from windows, and older children are at risk from falling from playground equipment. So the stronger we get, the more we grow, the higher the fall typically. Motor vehicle collisions. So 1/3 of children who die from trauma do so due to motor vehicle collisions. So this in itself makes motor vehicle collisions the leading cause of traumatic death and leading cause of permanent brain injury in children. And we'll talk about traumatic brain injuries later on in another lecture, but again, keep in mind, blunt trauma is the number one cause of death. So when we talk about these motor vehicle collisions, we're talking about traumatic injuries that are blunt trauma in etiology. Let's discuss vehicle versus pedestrian for a moment. So this is typically more common in urban areas or in cities where children play near or in the streets. Injuries typically are lethal due to the phases of collision. And I want you to think about the difference between a pediatric patient and an adult patient who's hit by a vehicle. When adults have a vehicle coming at them, what do? We turn to the side and we tuck and we try to protect ourselves from the impact. Conversely, kids are going to look right at the car and be like, yep, it's going to hit me. And then they get hit. So, and you have to think about where the vehicle is going to impact them as well, maybe face and chest. So that is where the first phase of the injury occurs. First phase of injury is where the vehicle connects with the child, and then from there, the child is propelled from the vehicle or pushed underneath the vehicle, which leads to the second phase of injury where the child connects with the ground or is run over by the vehicle itself. So pretty gnarly stuff. It's not good, but think about how it's different from the adult population. So submersions or immersion injuries. So we don't really toss the word drowning or near drowning around anymore. So let's discuss this a little further. The leading cause of death in boys from ages 1 to 4 years old is drowning, which is the process of experiencing respiratory impairment as the result of submersion or immersion in a liquid medium. So think about, we here in Region 2 in the state of Georgia, we have Lake Lanier. And, you know, as time goes on, there's a lot of rumors. There are a lot of speculations. People like to make fun and say that the lake is haunted because it was created over the top of a town. So, all that to say, there are a lot of deaths, and I don't know the statistics of it, but commonly these are young people. So drowning has 3 outcomes. No morbidity. So that means there is no problem. There's no insult. There is no deficit. Morbidity, which could mean some type of anoxic brain injury or some type of hypoxic event occurred that caused a deficit. Or mortality, which means that the patient died. So you either have fatal or non-fatal drowning events. The terms that we used to use back in the day, such as near drowning, are no longer utilized. So again, we're more specific. There's either morbidity, which means, again, some type of insult or permanent damage. Non-morbidity, which means nothing happened due to it. And mortality, which means that the event was fatal. So again, think about how the severe and irreversible anoxic, which means no oxygen, a lack of oxygen, how that will affect the patient during that time. Penetrating injuries. So due to an increase in violent crime, we also have an increase in the number of children with penetrating trauma. So kids with penetrating trauma, you need to think about how the risk of death actually increases with age. And children are usually innocent victims of these crimes. So think about that. And sometimes, unfortunately, as we will discuss in the abuse cases, they may be the intended victims. So always, 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 visual inspection of external injuries does not provide adequate evaluation of internal injuries. So that is what we mean by that is if you have a penetrating wound due to something stabbing a patient, or let's say if the patient fell onto something, we don't know the angle at which it entered the patient. We don't know the length of the object unless it's still there on scene. We don't know the speed at which it entered the patient. So there are a lot of different factors that you can't just say, okay, we have a little bit of external trauma here. And also you have to think about how tightly compressed the abdominal contents are, or the abdominal organs, and you have to think about peritoneal organs versus retroperitoneal organs. And you also have to think about if there is any type of abdominal penetrating trauma, you have to consider that there may be diaphragmatic involvement. So keep all of this in mind whenever we're talking about penetrating trauma later on. Burns. All right, so burns are one of the leading causes of accidental death in the home for children under 14 years of age. So anatomically, again, we've talked about this before, but children do not have the subcutaneous protection or the ability to thermoregulate that adults have. So think about that. So with that being said, you also have to think about the anatomical differences between a pediatric and adult, and that their face and head make up a larger percentage in proportion to body surface area. Therefore, that makes the airway a much larger concern with the pediatric patient. Also, immunologic development is still maturing, which makes infection even more likely for the pediatric patient. So keep all this in mind, in that kids will not compensate to burns quite as much as we will. All right, physical abuse. Again, we're going to have a lecture specifically over this, and we're going to have a guest come in who specializes in this to teach you some more specific signs and symptoms. However, physical abuse, children are at a high risk for physical abuse by adults and older children. So there are several different factors, including but not limited to socioeconomic status, poverty, domestic disturbances, younger parents, substance abuse, community violence. Also, whenever you run these calls, and again, we're going to talk about all the differences that you need to keep up with and all of the signs and symptoms that you need to be aware of. But remember to document all the pertinent findings, treatments, and interventions, and that it is your responsibility to report this to the proper authorities. So, again, if you did not document it, it did not happen. So let's talk about some pain medication that is suitable for pediatrics in the appropriate situations. So one thing to remember is that you should always stick to your local protocols and to what medical direction has already deemed appropriate for you. So by and large, caution and good assessment skills must be practiced and must be utilized with both morphine sulfate and fentanyl. Both medications have a potential for hypotension, although morphine has a little more vasodilatory effect. Fentanyl is not quite as vasoactive, but it still has the ability to do so. So also keep in mind respiratory depression with both medications. So if you do not give an appropriate dose for a patient, you may potentially overdose them and take out their respiratory drive by accident. So let's talk about morphine for a second. I want you to start off with 0.1 milligrams per kilogram, IM or IV. So these patients, typically you can go up to 5. Anything past that, you're going to have to ask for medical direction. Fentanyl. So fentanyl, it's a little more versatile in the way that it can be administered. So we can utilize fentanyl in that we can give 1 to 2 micrograms per kilogram IV or IM with a max of 50 to 100 micrograms per dose. Now you can also administer fentanyl intranasally using a mucosal atomizing device. So the dose for that is going to be 1.5 to 2 micrograms per kilogram intranasal. All right, so thanks for watching that short video over mechanism and the pain management that we can provide kids. I want to go ahead and find Pediatric Traumatic Emergencies Part 2, where we will talk about other boo-boos that hurt the babies. Email me with any questions, and we'll talk to you then. Thanks.